Hello, I'm Jack Cush, Executive Editor of RheumNow.com. This is the RheumNow Week in Review for 20th of January 2017. Thank you for tuning in. This week in the news, a registry of psoriasis patients from Sweden actually looked at 232 patients who were receiving biologics, and they compared those patients to those who were receiving disease-modifying drugs. And they found that over a period of follow-up that there was longer drug survival in those that were on the biologics, that those who received biologics actually had longer standing disease and more severe disease, that they ultimately had better PASI 75 scores, and as I said, they lasted longer on the drug, suggesting again maybe there's some superiority for biologic therapy over traditional DMARD therapy. Clearly there's a need for earlier and aggressive intervention when appropriate. We also retweeted this week a tweet from Ronan Kavanagh in Galway, where he found a nice article from Rheumatology Reviews of Nature's Review of Rheumatology, which had a nice piece on nicotine exacerbating arthritis, at least in a collagen-induced arthritis molecule. It looks like nicotine may be an inducer of NETs, neutrophil trapping, and what's called netosis, which can lead to activation of dendritic cells and B cell activation, and sort of perpetuate and amplify inflammatory responses. So nicotine, in addition to other things that we find going on in the lung with arthritis, this could be an independent mediator of disease activity in patients with arthritis. And he sort of postulates not only is it cigarettes, but maybe those who are taking nicotine via these e-cigarettes may also have and be at risk for more severe arthritis. Further research is needed. I tweeted some information this week about two lab measures that are gleaned from the CBC. One is the neutrophil to lymphocyte ratio, something that's usually most of us don't look at this, but there's a lot of literature out there about the utility of this particular ratio in determining outcomes. And it turns out that a neutrophil to lymphocyte ratio greater than 4 has been associated with more severe granulomatous polyangiitis patients, and especially those who have more renal disease. In other studies, it's been shown that high NLR, neutrophil to lymphocyte ratios, are also seen with other forms of inflammation, especially rheumatoid arthritis, inflammatory arthritis, those with cardiovascular disease and more aggressive cardiovascular disease, those who smoke, and those who have cancer. It can be associated with poorer outcomes in all of those conditions. Another measure from the simple CBC comes from RDW, the red cell distribution width, which it turns out that high values are associated with inflammation, also with thrombosis, risk of MI and cardiovascular events, anemia, poor prognosis, and outcomes in those with COPD and cancer. So again, a simple look at the CBC could be very telltale for a lot of your patients. A nice population-based study in Israel looked at their lupus population and the frequency of cancer. So in over 5,000 patients with lupus in Israel, they compared them 1 to 5 to the normal population, those without lupus, and found a threefold higher risk of cancer, especially for non-Hodgkin's lymphoma, Hodgkin's lymphoma, multiple myeloma, genitourinary malignancies in that order from highest to lowest. Again, a risk of cancer has been seen and reported for lupus. This sort of reaffirms some of that and gives some focus to some of the particular forms of cancer that may occur. A CDC report actually outlined 9 United States national parks wherein the ticks associated with Lyme disease have been shown to have be present and actually be therefore those who attend those national parks may be at risk. This includes national parks in Maine, Maryland, on Fire Island in New York, in Pennsylvania in the Gettysburg National Park, in the District of Columbia, and also in Virginia. The citation is on the website. A nice study published by Annals of Rheumatic Disease with Dr. Smolin as the lead author was reviewed on MedPage today. It's a study of 274 RA patients who were either treated with an IL-12 inhibitor, guselkumab, an IL-12/23 inhibitor, which is the marketed product ustekinumab, or a placebo. And it turns out that equal responses were seen in this fairly large study in patients with rheumatoid arthritis. Guselkumab gave an ACR20 of 41%, ustekinumab 54%, and placebo 40%, suggesting that these targets are not ones you should be looking to treat in patients with rheumatoid arthritis. This is not very similar to the data seen with the IL-17 inhibitors, wherein IL-17 obviously works very well in psoriatic and spondylitic disease, as does guselkumab and ustekinumab, but like placebo, does not work very well in rheumatoid arthritis. Instructive study about the basically taking bedside to bench to learn more about the pathogenesis of these diseases. A 240 patient study of giant cell arteritis showed that there was a high association with stroke. When they compared patients with GCA who had stroke versus those who didn't have stroke, they found that the stroke usually occurred at the time of diagnosis in about 3/4 of patients, which is the time to look for that and be aware of that. It turns out that the patients who had CVA were more likely to have ophthalmic symptoms of their GCA, have lower SED rates and CRPs and hemoglobins, lower inflammatory markers. And overall, when they looked at the involvement, they found more vertebrobasilar system involvement in such patients. A nice clue for those who manage patients with GCA. The FDA this past week approved the drug Xyrem, XYREM, also known as sodium oxybate. This drug was actually up for FDA approval last year for the treatment of a number of disorders, including fibromyalgia, and actually was voted down. Obviously, they went back to the FDA, reviewed their data, and now they came across with a more restrictive indication, and now with an aggressive and strong REMS program to ensure the safety of the drug. The drug is being approved for cataplexy and for those patients with narcolepsy and excessive daytime sleepiness. So that information is out there for those who may require that drug. 141 patients with rheumatoid arthritis were studied for the associations that may be seen with ultrasound synovitis. And they looked at a number of different biomarkers, including the SED rate, CRP, IL-6 levels, VEGF levels, vascular endothelial growth factors, and calprotectin. And it turns out that calprotectin had the greatest association with ultrasound synovitis scores and had the greatest correlation. Again, calprotectin keeps showing up as a nice biomarker. It's being used in GI, mainly in the form of calprotectin levels within the stool. But in rheumatoid arthritis, inflammatory arthritis, this is a good marker to look at in the serum. It's generally not available, but I would imagine in the near future it will be available. By the way, calprotectin is not part of one of the 12 biomarkers measured for in the Vectra test. A nice review of renal disease and scleroderma showed that renal crisis, thankfully, is a low-frequency event, but it can be as high as 15%. It usually occurs in the first 5 years of systemic sclerosis. And again, patients who are aggressively treated with ACE inhibitors tend to do better, avoiding either renal crisis and certainly having better overall survival and renal survival. And lastly, there was an updated report on the development of baricitinib, the drug being developed as a JAK inhibitor for rheumatoid arthritis, soon to be decided upon by the FDA, but the FDA announced this week that they were extending their review by another 3 months, pending further review of more information. There's no particular problems with the information, it's just that there's a large file of information to review, and we probably can expect a decision by the FDA by the end of March or early April about baricitinib. On the website, we had reports this week about guidelines for treatment of juvenile dermatomyositis and also revised EULAR guidelines on fibromyalgia. These are sort of long papers about and with a lot of detailed information about methodology. The website, we just put up the recommendations, the overarching principles, the recommendations for both the diagnosis and the treatment. I think you'll find those instructive and either will reinforce some of the things you do and make you think about some of the things you may not be doing. There was a nice report about diet triggering inflammation on the website's Science Daily. And it is a nice review and shows how diet may very well be important in ways above that and beyond what we're now talking about with regard to the microbiome. The point being that patients who have diabetes and obviously hyperinsulinemia have a lot of chronic inflammation, the consequences of that on their vasculature and other organs. And this review talks about what it takes to digest food and sugars in particular, and it actually involves the activation of macrophages, leading to the production of interleukin-1 beta, which further engages and controls pancreatic-produced insulin to regulate how much glucose is going to be absorbed and how much of that IL-1 and then insulin is produced is done in proportion to blood sugar levels. And then, if unregulated and perpetuated, can lead to chronic inflammation and activation of the inflammasome and other downstream events, showing that, again, dietary intake may be very important to chronic inflammation. There was a nice review, or original report in Annals of Internal Medicine this week of over 500 patients in the Duke healthcare system, a multi-center study where patients were either treated for their osteoarthritis with either the usual interventions and then the other, which was the control group, and then two interventions, one being a patient education intervention and then the other being a provider intervention. Both of these were sort of low intensity. The patient intervention were phone calls designed to educate the patient and talk about diet and exercise and whatnot. And the provider intervention was the providers being sent educational information about the best management of osteoarthritis. And it turns out that there was no difference between above and beyond the usual care for those who got either provider intervention or patient intervention. This was a bit disappointing because you would think that educational efforts might have downstream benefits to the patient, but in this 12-month study, there was no sort of long-term benefit. And other studies have shown that there might be benefits to such interventions. Probably has a lot to do with, one, the intensity and scope of intervention that's used on patients or providers, and two, the time point at which you're measuring the outcomes. Short-term outcomes and benefits are much easier to achieve than long-term outcomes of 1 year or more. And that may be one of the takeaways of that study. And lastly, a nice review of about 53 patients treated with ANCA-associated vasculitis and treated with rituximab, looked at its effects on IgG production and ANCA titers, and they did see that there was a steady decline in IgG production, that you could reduce ANCA titers by an average of 46%. The same could be said for MPO and PR3 antibody titers in those who received rituximab. 4.6% of patients developed a chronically low IgG level. Although that was independently associated with the risk of infection, the risk of infection was seen in 8.5 serious infections per 100 patient years. So this data sort of suggests that those receiving rituximab should be monitored for their ANCA levels and their IgG levels. It may tell you about the success of therapy and the risk of future infection, and may help you to guide therapy. I used to be one who thought that ANCA was important in those on vasculitis. The literature 10, 12, 15 years ago said, no, that's not true. It's not a good biomarker. More recently, it turns out that it seems like there may be a good reason to follow ANCA levels in patients who are treated with ANCA-associated vasculitis to gauge the success, because if you have patients in whom those titers are responsive, it becomes a useful tool in assessing such patients. So that's it for this week at RheumNow.com. You can go to the website and find the links to these and many more citations which you'll find interesting. We'll see you next week. Have a great week. That's it for RheumNow.